Hello, everyone. Thank you so much for the opportunity to be with you today at the National Breastfeeding Coalition Conference Reimagined for 2020. We are delighted to be here today to talk to you about our project, Addressing Community Gaps in Breastfeeding from the Hospital to the First Visit. Next slide. You see our team who has already been introduced to you. But some of the folks on this slide are not able to be with us today. We're delighted to have neonatologists, pediatricians, community health workers, IBCLCs, both in the prenatal and in the primary care setting, and a brand new primary care doctor just completing her residency with us. Next slide. Our objectives today are to explain quality improvement tools, including an aim statement, a key driver diagram, a PDSA cycle, and a Pareto chart, and to describe how a multidisciplinary team can help address the gaps of breastfeeding care. Next slide. So by way of background, we have three main primary care clinics at Cincinnati Children's, a large academic pediatric hospital with a high volume of Medicaid patients, about 85% coming to each clinic. We also have a neonatology pediatric physician group called Newborn Care Associates that staff most of our birth hospitals in the area. And we also have ongoing quality improvement work with our area birth hospitals to increase exclusive breastfeeding in the hospital. Next slide. Now I'm turning it over to my colleague and quality improvement guru, Dr. Laura Ward.
Hi, everyone. It's a pleasure to be with you today. So I'm wondering how many of you have ever heard of a SMART aim or know what it stands for. I'm going to talk a little bit more about this in our next slide. So this is our key driver diagram. And this is a tool that can help the team to organize their theory for improvement for a specific project by organizing and connecting the outcome, the drivers of the outcome, and the interventions and tests of change. The key driver diagram can also serve as a means to communicate a project. And it should be something that evolves over time as the project progresses and learning occurs. You might note on the top right-hand side, we recently revised our key driver diagram. This is version number 5. Now let me turn your attention to the left-hand column where we have our aim statements. We have a global aim and a SMART aim. Our global aim is our overall big picture outcome. So in our case, our global aim is to improve breastfeeding rates in patients at the pediatric primary care clinic at Cincinnati Children's. Our specific aim, also known as our SMART aim, is an acronym for specific, measurable, actionable, relevant, and time-bound. So in our project, our SMART aim is to increase the number of babies continuing to receive breast milk at the first visit to the clinic by 5% within the next 12 months, so by June of 2021. The middle column is our key drivers. These are the leading factors that we think impact our outcome. The key driver is the what, while the interventions are the how. And traditionally, we describe our key drivers in the affirmative. So the key drivers for our project, what factors we think impact our outcome of increasing the number of babies continuing to breastfeed after discharge at their first newborn visit. These include consistent breastfeeding education and counseling at the birth hospital by the entire care team, community, family, and peer support of breastfeeding, an adequate, abundant maternal milk supply, availability of timely and accurate data, knowledge and understanding by the care team of maternal stressors that could potentially impact breastfeeding, consistent and adequate latch by the baby, and a timely newborn visit following hospital discharge. So now our interventions, which are in the right-hand column. These are the what's. These are what we have focused on. So we've targeted the medical records at both the birth hospitals as well as the hospital clinics with SMART phrases to ensure that we're getting consistent, accurate data regarding feeding method. We've shared our data on breastfeeding rates at the first newborn visit with breastfeeding quality improvement teams that meet monthly as a region. And we've also shared breastfeeding resources with these teams so as to bridge the gap between hospital discharge and follow-up. Lastly, our newborn coordinator in our clinic has made phone calls with our moms to check in. Now you'll notice there are a couple of white boxes in our interventions. These represent interventions that are not yet in place, but things that we are working on and potential interventions. They include an infographic on breastfeeding discharge teaching and a texting system to communicate with moms after discharge before the first follow-up visit. You'll also notice that the interventions are labeled with a level of reliability, or LOR. Reliability is the relative capability of a process to perform the intended function under existing conditions in a timely manner. So the higher the level, the more reliable a process is. So as an example, something like education that needs frequent reinforcement, that has a lower level of reliability than something that's automated and more automatic. And I think at this point, I'll turn it back to Julie.
This slide shows us where we are at breastfeeding at all 3 primary care clinics. We have an aggregate number of breastfeeders at the newborn, 2-month, 4 months, 6 months, and so on. And you can see that about 64% in 2020 of newborns coming to their first visit at any one of our 3 clinics is receiving some mother's milk. You see the decline after that first visit, as is recognized all across the nation. What's very nice about our project is with our connection with our birth hospital group, we know that the average initiation of breastfeeding at 4 of the major hospitals sending babies to our primary care clinics is about 83%. And we are talking in our entire project about any breastfeeding. So we look there and we see a gap between any breastfeeding in the hospital and the first newborn visit. And it's really important to note, though, that our primary care clinics don't see all the babies coming from these hospitals. It can range from 6 to 20%, depending on the hospital, who will come to our primary care clinics. So we are very interested in looking at the gap between initiation and continuation of breastfeeding. This is in line with step 10 of the 10 steps to successful breastfeeding to support mothers as they go home from the hospital. Next slide. So we're going to take you through some measures. Quality improvement needs us to measure something to know that any changes we make, whether it makes an improvement or not. So these next few slides will be about our breastfeeding at the first visit to our clinics. And what you'll probably notice right at the start is this number, the red solid line, is higher than what we were just talking about on the previous slide, because what we decided to do for our project was to look first at just those babies who started breastfeeding in the birth hospital. So if they started any breastfeeding in the birth hospital, they are a part of this project. And what we found when we started looking at that group was that at our biggest clinic, we had about 88% breastfeeding initially as we started the project, and up to about 93% breastfeeding after the project started getting going. In the boxes you'll see here, we have some of those interventions that Dr. Ward mentioned that we've been working on in the project. And you can also see along the x-axis that how many babies are coming to the clinic every month. So we have a lot of babies coming to Clinic A, 88 to 93, I'm sorry, 33 to 78 babies in a range. And so this is a very busy clinic. Now, next slide Clinic B, we have not been able to collect data for as long with Clinic B, but also has quite a few babies coming, 26 to 47 babies, and about 89% of babies are still breastfeeding at that first visit. And what we know is that means 11% of babies started breastfeeding, but for some reason did not get to continue breastfeeding. So room for improvement. And then our Clinic C, our next slide, this clinic has a lot of babies still breastfeeding at the first visit. About 96% are still breastfeeding at the first visit. So very, very many are still continuing to breastfeed. Now the next slide, we are going to dive into what's happening at our birth hospitals. So we have about 11 birth hospitals who feed babies into our clinics. And the range of births in these hospitals is from 500 to 5,000. And we're only going to highlight 4 of them for you today that we've been able to aggregate numbers based on coming to our 3 clinics. Next slide. So Hospital 1, aggregate still breastfeeding at the first visit. This takes into account any baby who came to any of our 3 clinics who was born at Hospital 1. And Hospital 1 has about 94% of babies still breastfeeding at that first visit, numbering from 17 to 32 babies overall. Next slide. Hospital 2, we have about 92% still breastfeeding at the first visit, a little bit less in numbers coming to our clinics, about 8 to 17 per month. And then Hospital 3, next slide, we have a bigger room for improvement with Hospital 3. We have about 86% of babies are still breastfeeding at the first visit. So that means 14% of them started breastfeeding, but are no longer breastfeeding by that first newborn visit. And then finally, Hospital 4 is doing very well at 100% at the first visit, still breastfeeding. The numbers you'll notice on the x-axis are a smaller number of babies from Hospital 4, but definitely something we want to explore in more detail because they're doing so well. And now, next slide, it's my privilege to turn this over to Dr. Erica Walters, our new primary care doctor just finishing her training with us.
Thank you, Julie. So I'm curious, what have you heard moms say? Why do they decide to stop breastfeeding? Here's a Pareto chart showing the reasons mothers decided to quit breastfeeding before the first newborn visit. If you're not familiar with the Pareto chart, the vertical bars represent the reasons mothers cited for discontinuing breastfeeding, going from most frequent to least frequent, and the line graph along the top represents the cumulative percentage. The number associated with each bar represents the number of mothers who provided that reason. At the beginning of our project, we developed a survey to systematically interview mothers as to why they chose to discontinue breastfeeding. Over the course of the year, I attempted to call 75 mothers who had switched to only formula feeding at their first newborn visit and was only able to reach 22 of the mothers, or about 30%. So I think it's important to highlight that this is just a snapshot of a portion of the population. However, what our moms reported is similar to what previous research has shown. As you can see, there were over 22 responses, as several mothers reported multiple reasons that they just chose to discontinue breastfeeding. The most common reasons mothers chose to stop breastfeeding was that they felt there was not enough milk. Either they perceived their milk supply was insufficient or the infant was not transferring a sufficient amount of milk. Many mothers also reported difficulty latching the infant and pain as reasons for discontinuation of breastfeeding. Medical reasons such as maternal medications, jaundice, and prematurity, as well as social and emotional reasons, were less frequently cited but still reported. And next we'll have Dr. Jenny McAllister talk about what we can do to improve these numbers.
Thank you, Erica. And as Laura had described, we are looking at an overall model of improvement. And so what we're trying to accomplish with this project is our aim. And Julia described the measures in which we look to see if our change is improving. What I'm going to focus on now is how we can implement small tests of change that result in improvement. And so a question for you is, how many of you have ever participated in a PDSA cycle? So PDSA stands for Plan, Do, Study, Act. This is our model of how we implement small tests of change to impact our larger aim. And so the plan portion of the PDSA is the blueprint of our test. So we look at what the objective of the test is. We develop an action plan for the test. So that looks at the who, the what, the where, and the when. And then we look at how the impact of the test will be measured and what we will predict will happen. The do portion is actually implementing that test of change and evaluating the results. And finally, we study our cycle. So were our predictions correct? And what should we do next? Wrapping everything up is the act portion. And so in the act, we have three options. We can adapt our project. So were there small revisions that we need to make and then we retest? Are we able to scale up? So we started small with just one patient or one hospital, and then we moved on to more patients and multiple hospitals. We can adopt our cycle and test it under different conditions to see if we have the same results. And finally, the last option is abandon. So did our test fail, but we were able to learn something from the process? And so what I'm going to describe here is our PDSA cycle that looks specifically at a discharge smart phrase or dot phrase that we used in the birth hospitals at the time of discharge to help communicate information to the clinics receiving these babies at the first newborn visit. And what you see here is a PDSA worksheet, which helps organize your project to have everything in front of you to give a nice outline. And links for these worksheets are available at the end of our talk, but are also found online. So looking specifically at our project, the intervention that I'm going to discuss is this new smart phrase that were implemented at the birth hospitals. And blowing up the section of the worksheet that describes our plan, our test was a standardized dot phrase that physicians would fill out at the time of discharge, which describes the infant's feeding method during the hospitalization. This helps ensure that accurate information is being portrayed and the discharge summary that is communicated back to the providers at the newborn clinic. Previously, feeding method may have been pulled in from flow sheets that were automated but not necessarily accurate. And as you can see here, this is an example of that discharge dot phrase. The highlighted portions are what is required of the physician to choose before moving on and being able to complete the note. How we knew that the change was an improvement is we looked at what moms were reporting that they did during the hospital to see if it matched what was recorded in the discharge summary. The key driver that it impacted was the availability of timely and accurate data. And our prediction was that our data would show that more mothers were actually providing some breast milk than what was being shown previously at the time of discharge. Looking at the tasks needed to complete this cycle is that we had to physically create that smart phrase in our electronic medical record system. We had to educate our physicians about making sure they use that smart phrase. And finally, we collected data about this discharge feeding type to see our numbers. Looking at the do, study, act portion of this cycle is that we implemented the change and we implemented that smart phrase, and it was carried out as planned without too many major hiccups. What we did observe that was not initially part of our plan is that some mothers actually started breastfeeding at home, but were not breastfeeding while in the hospital, and we weren't expecting this. So these moms were not picked up at the time of discharge in our discharge summary with that dot phrase because they were not breastfeeding at the time during the hospitalization. But overall, our results matched our predictions, and we had fewer misclassifications of feeding type noted at the first visit. And so we adopted this test, this change, and we implemented it on a larger scale. So we started at just one hospital and then scaled it up to all the multiple hospitals that we serve. And looking at our next PDSA cycle, the intervention that we are going to work on next is implementing a similar smart phrase for mothers who are using nipple shields at the time of discharge. And so the drivers we are hoping to impact would look at specifically at the latch and ensuring timely follow-up. And what we're hoping to implement are some newborn calls and texts prior to the first visit to help identify these mothers, to help ensure proper follow-up so that these moms don't discontinue breastfeeding in that gap due to these reasons. And it is my pleasure now to turn it over to Suzanne, who will talk about some prenatal interventions.
So I'm Suzanne Crable, and I wonder what you are doing prenatally to prepare mothers for a successful breastfeeding course. Next slide. So we received at Hospital One the ability to transform the care that we deliver to mothers. And this involved having me available for prenatal contact 2 to 3 times, usually early on at about 20 to 24 weeks. Then again, perhaps to help order a pump. And then recently we've started a little pre-delivery pep talk to prepare for the first 3 days, what to expect those days in the hospital. A monthly breastfeeding class is available, although lately we've taken to private breastfeeding classes after a visit. We have centering pregnancy, which we're working on having that be the default setting for most mothers to enter centering pregnancy. And I visit them again early on and then later, and also help with pumps for home. When I'm able to, I visit them on the postpartum unit to make sure things are going smoothly for them. We have lactation consultants on the mother-baby unit daily, but just a little bit extra care and touch with them. I text them after discharge, and then there's ongoing text and phone support, sometimes many weeks or months out, establishing that trust for them to continue to breastfeed. And then, if needed, a free outpatient visit is available. We will be moving into a new space later on this summer, and that should enable us to be right there. Also, what I give to them at the 20-week mark or so is a congratulations note that they're making milk. That seems to be the major problem that mothers think that they have, not always, that they do have, but congratulations, you're making milk now and we'll keep making milk. Next slide. Because every mother uses the bathroom in the hospital, we've created, and it's in progress, a little infographic to put on the back of the bathroom door, just going over those main points that mothers need to remember. Positioning, number of feedings per day, the number of diapers that she needs to be watching for, reminding that babies will sometimes lose weight and that babies tend to be eating a lot at night. And hopefully that gets them through with, if not exclusive breastfeeding, at least continuing to breastfeed throughout that hospital stay. Next slide. And here are some tools that I use to send to moms when I text them when they get home. The first droplet website is wonderful. Our WIC in our county has great videos that are easy for moms to access. And then you probably know about Global Health Media's videos, which are very helpful, and Kelly Mom for good evidence-based information. Now, I'm turning over to my colleague Robin Steffen at the Pediatric Primary Care Center.
Thank you, Suzanne. My question is, those of you who work in the primary care setting, what are you doing in your clinics to try to help support your breastfeeding family? At our primary care offices, we have implemented having certified lactation counselors at each location and one IBCLC to try to have contact with all of our breastfeeding families at their newborn visit. And we also try to see those that have stopped breastfeeding since discharge, just to see if there's any concerns that we can help address and possibly get them back on track. We review a flow chart for feeding at the first visit to make sure that it is correct as compared to the discharge summary from the hospital, and then what they tell us during our time with them in the room. We assess breastfeeding whenever possible. Sometimes it's not possible. Maybe the baby has fed recently, but we really do encourage moms to have us watch a feeding along with them, just to help assess and reinforce some of the things that they've learned prenatally and in the birth hospital. We provide a lot of education on breastfeeding, and we give them a packet of information and resources in our area. As you can see in the picture to the right there, that goes to every breastfeeding newborn at the newborn visit. We also try to follow up with newborns that are no-shows to their first appointment. We first try to call them, and if we can't get them by phone, then we try to send them a text to see if we can help them until they can get actually physically into our location. We also are trying to get more CLCs trained, not only for our own clinics, but in our general region, and as well as community breastfeeding educators in our region and in our own organization. We also have videos that we like to share. The global health media videos are always a favorite. The attaching your baby at the breast is an especially helpful one if we don't get to see a baby latch at the newborn visit. We also, the laid back position is kind of hard to do even in our clinic, so that video can be very nice for mothers. And then hand expressing breast milk, of course, is moms sometimes don't want to try that with us while they're here. Next slide. And now I'm going to turn it back over to Dr. Julie Ware.
Thank you, Robin. So we love sharing resources with our community, as you've heard from my colleagues on the webinar so far. What do you all think are the most important resources to share both with mothers and providers? So we have been getting creative with COVID-19, as all of us have had to do. And I thought it was very pertinent to a USBC webinar to talk about the collaboration we've had across state lines with some of the tools that we've been using. So we've been pushing out this Breast Beginnings app that was developed by our colleague in Kentucky for mothers to learn about breastfeeding, and it's nicely broken down into the different days of life, including this newborn period that we're talking about. We are delighted with the Bella prenatal education video from our colleagues up in Massachusetts. And then we were very thankful that our Carolina Global Breastfeeding Initiative friends shared their Ready, Set, Baby virtual classes with us for prenatal education, because it's been so hard for mothers to get that care prenatally in our area. And then we've switched formats for some of our local breastfeeding support groups to be virtual. So we have a flyer here of our Amen support group that has gone virtual for the moms to help provide care during that gap. And next slide. We've taken all of our resources that are abundant in our area for mothers and tried to update for our colleagues and the mothers as well what's happening right now in the time of COVID, who's open, who can see patients, who can do virtual visits and that sort of thing. So we're trying to keep that up to date as best as we can. And next slide. So we have had a lot of fun in this project, but we have a lot of next steps to think about doing. We really want to look at that hospital 4 group at 100%. We really are excited about Suzanne's bathroom one-pager and testing that out in PDSA cycles. We are excited to continue sharing resources widely across our community, and we'd love to engage more frontline workers from all the birth hospitals to be part of our team. And we really want to get together more with community moms to find out what we can do to help them. And we are very excited about texting as a next step. Next slide. The next several slides, we can just flip through them, are resources for you to look through and go back and get more information about some of the resources we've highlighted today. And then finally, the last slide is our take-home lessons are that gaps in breastfeeding support need a multi-pronged approach and really must include all partners, some of whom you've seen today, the prenatal arena, our birth hospitals, our primary care, and our community. And that small tests of change through quality improvement methodology really can help us to achieve our goal of supporting more mothers to successfully breastfeed. And we thank you very, very much for the opportunity to be with you today. It's been a joy.